now your opportunity to ask any questions that you have. Or is there things that you wanted to bring up first, Amanda?
I just think I'd probably just in terms of the data collection, certainly the advice that I had when I hadn't spoken to the practices, and John will certainly be guided by you as well, is that because we have got some practices that aren't using MD, although everyone in the room is, I was advised that to configure the actual clinical coding for this purpose, it would take a little bit of time for that to happen. So one thing we've looked at is an Excel spreadsheet that does actually capture all that information, but in a spreadsheet. So in the clinical notes, that information would still be entered as you would any routine consultation, whatever transpired, but that arrangements would be in place that to capture that. I think you've got a copy of the spreadsheet in there, and I think I've sent it to you electronically. Not yet? Alright. Capturing all that information as to whether the tool was offered to the patient, whether they accepted to undertake the screening tool, whether they're at moderate to high risk, but I'll change the terminology so that it's consistent with increased or average risk, and whether they were booked for a recall appointment, and whether the patient actually attended the recall. So we're at least capturing that information in some form or other. So
that's fine, as long as there's a process.
Excellent.
Yeah.
So depending on method 1 versus method 2, I've slightly configured the Excel spreadsheet just to put in another element into that, that if the patient is completing the tool in the waiting room area, that there is a section in there that the GP or practice nurse has cited the tool itself, like cited the questionnaire and signing for that they have cited it, just as an added element to manage that clinical risk that the patient hasn't filled it out and then it's just disappeared with the tool. Unfortunately, I'm going to be away over these next couple of weeks when the project rolls out, but certainly the MDIs and the various LGAs, if you've got any questions regarding the data collection, to give the girls a call. I'll certainly be in contact with you that first week I'm back as of the 15th of April, just to touch base with any other issues. But the first round of data will be at the end of May, so that we're running reports essentially every 2 months, so that it's not hopefully a huge burdensome task to run a report at the end, which we could be dealing with larger numbers. Does anyone have any questions with regards to the data?
Not an issue, but I can see this being a problem, just the sentence that you've written down the bottom. Once you complete this questionnaire, please hand back to reception staff. The GP will review your answers and speak to you about your family cancer risk. That suggests to the patient, if I was reading that in the waiting room, that would suggest that you're going to sit down at the time and have a chat about familial cancer. I would have thought a better line would be something around the lines of, your questionnaire will be given to a doctor in the practice who will then assess your risk, and you will be run if you fall into a high risk group and offered or invited to come back for a consultation about your risk and assessment. Because that,
sure.
We've done other surveys before, and the patient comes in with their diabetes ones and stuff, and wants to talk about diabetes. And if you're running an hour late, you can't do that then. It's just not feasible. So I would think this would be better to go back into a box. Then you're going to get them all for a start. They're not going to be on some doctors. We've got 9 doctors in our practice on a different doctor's desk all around. You're never going to see them again. Then they're all collated at once, and we go through, one doctor goes through it, 2 doctors go through it and say, okay, there's your risk. These ones are at high risk, these ones are at no risk. You can automatically put it all back on the form, and then you invite the patients back. That would seem much more logical.
Yeah, I'd agree. I mean, that's sort of why we needed to have this meeting today, to discuss what's going to work best for you. And as you say, the idea is not that they have a detailed discussion about their risk in immediately after they've completed this. They need to have a separate appointment made for that.
Yeah.
And so we probably do need to reword this final bit.
I just think your data collection is going to be a lot easier.
And that's
too.
true as well. And so within the waiting room model,
Yeah.
maybe having a box
What do you
and
mean?
so that you're capturing them all as well.
Yeah.
And then
Privacy thing too, because you've got the name on it.
Yeah.
It just sits in there, unless if it goes back.
Yeah, that's what I reckon.
One
If it goes back in,
person's-
and one
Mm.
person is, or one, maybe two each week a particular doctor in the practice, or a couple of doctors will have the opportunity to go through and go, right, yeah, okay, you're at high risk, you're at low risk, okay. Then, okay, those names go onto the form. It just, for me, it just seems much more, that it'll work better and the data collection will be much better.
Yeah.
And it won't disrupt the clinic, and then patients will have that opportunity. So if you face them with that, some of them don't want to talk about it, some of them don't want to go down that line.
yeah, absolutely.
You've got to give them the opportunity.
Yeah.
Sort of,
I mean, in the actual fact, because you basically, if they're all no's, it's really very straightforward, and you may not even need a doctor to be reviewing it.
I mean, anybody.
Yeah, because it's more a matter of seeing, yeah, clearly it's any yes, then they need to be followed up. And it's meant to be as simple as that. That it doesn't require medical input at that point to decide who needs to be followed up.
Okay, so Joanne, so your preference would be to have that line
That line taken out. Something at the bottom of the thing saying like all questionnaires will be assessed by a doctor. Then if you are deemed to be at high risk, you will be invited back to have a further more detailed risk assessment and explanation or whatever. You can put whatever you like, but I've just quickly wrote down,
So I guess one of the questions is to make sure that, because at the time the patient might know that there is processes in place for patients to be advised if it is a negative, like if they've answered no to everything, that the practices have got something in place to actually inform those patients of those results as well. That they're
I would have thought that if they were answered negative to everything, that they would assume they're at low risk. But yeah, I guess the nose could be run as well.
It might be worth sending out something to them because you don't know. And I was going to ask about your first group of patients and their behavioural changes and the ones that weren't at risk. Did they just think, oh, well, I don't need to do any screening at all? And so would it be worth sending out a leaflet going, look, you haven't at this point, but please do your regular screening.
Yeah, no, that's a good point.
Regular
So-
regular pad,
That's
regular,
right.
that should.
So that would be a good way of just confirming that they still
Yeah.
need
And if it's
their
just
normal.
sent out,
Yeah,
it can be done as
That's a good
a.
idea.
that is a good idea. So a letter just saying, well, at this age you need this. And,
Yeah.
yeah.
And that's a reception.
A standard routine.
Yeah.
Okay.
Together.
Is that data going to be de-identified? I can see we've got the patient name on this spreadsheet.
Yep. Yes, absolutely. So practices, I'm not sure who your practice visited, but certainly when the information comes back to us, you don't want the patient name, just their ages. So that field was either to be hidden or if you're faxing it back, just to, it's probably easier to have electronically email to us so you can hide that section. So
Okay.
yeah, absolutely, that it is de-identified data that we're dealing with.
And did you say that every questionnaire has to have a number that we give out? So
This is one of the issues, I guess, is that we, can't control like how many, because everyone's going to be at different stages of numbers, so it's going to be again, up to the practices to work out, do you want this electronically sent to you so that you can run off page numbers, or because I think keeping track of that from our end of things is going to be very difficult. So
we just label that, do we? That sheet as a 1, 2, 3,
Yeah,
and
that's
so
right.
forth.
yeah.
It's just another way of tracking how many you've handed out. Yeah. Because inevitably, particularly in the waiting room, there will be some that will be just scribbled on and that won't get completed.
Just one question too. If you've got country of birth and on this you've got nationality, what?
Had this debate at work the other day. I think
So you've got what's known background born in Australia? What do you call them?
I think we were looking at changing it to country of birth rather than nationality. Because,
So you're asking that for a different reason. We're not using that in the risk assessment. That's part of your understanding of the demographics of the people who are completing this. Yeah.
So country of birth, not
country
national.
of birth, yeah.
And what's the target group age?
It's 18 to 65.
I mean, this is probably of most relevance to when we were first doing this of people 18 to 50, because they're the group who don't currently fall into the national screening programs, but may actually require earlier screening. But there's no reason not to be offering it to people who are older, because they may actually their children might be at increased risk.
So do you want us to approach it to just put it to 65 or?
I mean, the difficulty with that, of course, is then selecting out who in the waiting room. And so you're very welcome just to make it open to all adults.
But then the project you just want it to 65.
Well, look, I'm rather more relaxed about that. We don't want children completing it. But it can be open to all adults, and as long as we've got their information about their age, because a risk assessment can be relevant, particularly if they were identified as being a high-risk family, then it's going to be very relevant to their children. Is that all right, Amanda? You've got
Sure, I'm writing those here.
Because it really does look a very valuable thing to pull up, standard apart from the project.
Yeah. Well, we would like to see this just in routine practice. This is a matter of working out how best to make it work for you. Yeah.
I mean, our reception, like we've had other surveys for in other risk categories, our reception staff would know how old each patient is because it's
Sure.
it's on the computer. So perhaps we'll give it out to the
Yeah. Yeah, it's just it's whether it's another job for your reception staff, isn't it? But, to have to check their age, because presumably it wouldn't come up just when you see them on their appointment list.
it does.
Okay.
The only other thing is putting the age on there, because people will go on 65 or I'm 75 or whatever they're looking at. They could return it back to you.
So to check individuals with breast cancer is between the age of 18 and 65.
Yeah, exactly. So look at
Someone will say, can I have one too?
Yeah.
No, I'm sorry. Maybe 61.
It's a bit like we're not interested in you now.
I suppose the one that's got cancer at the moment isn't excluded.
No, they would essentially count within the risk assessment as an affected relative, and then if they had other affected relatives, you would count them as an affected relative. I mean, that's particularly when you're thinking about the high risk families. So somebody who's been affected, they may well have not had their family history taken when they were diagnosed. And that's improving, particularly for colorectal cancer, but it's not always taken. And so it would be important to take the rest of their family history, and if they've got obviously multiple relatives, then you would count them as an affected relative as well, essentially, when you're doing your risk assessment.
So if that woman had had breast cancer that no one else in her family has,
then it's really only her daughters that would be at increased risk. But
would she get a tick on this spread?
No, she wouldn't. No. And so there is that potential for those to fall through the cracks. I mean, you could, if you wanted, have an additional question, have you been diagnosed with any of these cancers? But that's the main purpose of this, is obviously about finding people with a family history, and I guess we don't want to make this more complicated.
Presumably the people who have already been diagnosed are already being followed up.
They will be being followed up, yes, though, you know, it is possible that they may not have had their family history taken. The people who are in the consultation group, how do you think, which ones are you in the consultation room now? You are. How do you think it's going to work?
I think it can work quite well. It's a chance to have a discussion about sort of family history. And for a lot of people, it's going to be pretty straightforward. People, but then the ones that are, the difficult thing will be then to get them to come back for the follow-up rather than doing it.
Sure. Yes. Yeah. But I guess, you know, you have to say that this is just meant to be a very simple thing to begin with, but we need to take time to take your family history in more detail. And you can also say it can be useful to go back and check the details of your family history before you come in for that.
With recording the family history tree, how can you do that in medical director? Or?
No, not in medical director, unfortunately. I mean, I guess if you really wanted to, you could, by paper, draw the pedigree and then scan it in. There aren't any simple pedigree drawing tools out there yet to allow you to do all of that electronically. But that would be one option. And alternatively, you just have to list it all in text in medical director as to the age of each individual affected relative.
Is it worth having some copy templates then that the GPs
For the-
just easily?
That's a good idea.
Yeah.
Or like some reason for publishing, is there something in there that would...
For the MD template, do you mean, or a pedigree template?
Yeah, pedigree, so that it's all there, so they can just fill it out and go down, and it can just be scanned into their notes, so you're not sitting there drawing so much.
The difficulty with that is that everybody's tree is slightly different. So some people will be more familiar with drawing pedigrees. If you like, there are some resources about drawing pedigrees that we can share if you want to think about going that route. Okay, I can tell you where they are. Yeah. There's a website that it's Genetics in Family Medicine that is on the NHMRC website, and it's got a whole load of resources around genetics as it applies to general practice. And within that, there's a section around taking family history and drawing pedigrees, but we'll pull it out.
Just going back to Kay's suggestion with regards to the standard letter template for those patients that are at low to no risk. Is that something the practices yourselves would generate, or do you want me to see if I can put something together and then you can modify it as need be?
That's right.
The screening,
Yeah.
continued screening and things.
Well, we could certainly do that. Because a lot of it's just about reinforcing the messages in the Red Book.
Yeah, that's right. Yeah.
And so we could easily,
Our
I can do that.
You can do that? That'd be good, man, John.
Tip to John. And then the format for those that are with the yeses, they will be run, or that's what we've got to decide.
So at a practice level to make that determination in terms of how
So however you would follow up people with any abnormal result really.
Become a recall and.
Yeah.
Yeah. And that's what we're sort of talking about, having MD configured so that you recall your cancer, if you're on history of cancer recall, can be put onto your MD to do it that way so you can run the report straight off.
What happens if they don't respond, then they just go in there?
If they don't attend the recall, yeah.
And know too that that's
Hmm.
not good.
And then, yeah.
Yeah. And it would be worth somehow flagging that on their record if you can,
Because, yeah,
for a discussion when they do come in next if they decline the appointment.
Is there going to be any formal training at all so that we're giving the same advice? Or is it basically just following the guidelines in the red book? Is that what it is?
This is, I mean, obviously this is part of the discussion, but and this is really the training in terms of the process, and the implementation of consistency is around ensuring that whoever's doing the risk assessment has the Red Book guidelines that they're familiar with, which they presumably we've got laminated copies of those guidelines. We will need to, yeah.
No, but that's all your practices got. Copies of the Red Book? Yeah.
We've got a red book, but it's not up to date.
No. So the up-to-date one
It's on the
is
website.
just on the website, yeah. But if you want a hard copy as well, because it's easier to refer to, with just the specifics for the cancers that are being covered, I think that would
We
be
probably
useful.
must have laminated too.
That's
Yeah.
right, yeah.
Yeah, what I can do is mail those out. You do? I can send them electronically, or if you prefer, I can mail them out to you, laminate, whatever. If you've all got laminates, it'd be great.
Yeah, you could just do it because then we can do certain copies and one.
Yep, alright.
For each.
Fine.
Yeah.
Any other questions? Can I just 2 minutes of your time just to mention one other study, and actually, would you mind just passing these around at the same time? It's another study another cancer screening study that we're looking to recruit practice into, and it's about Barrett's esophagus, which is a pre-cancerous lesion in the esophagus, which puts people at high risk of esophageal cancer. And at the moment, the only screening test for it is an endoscopy. People who are at increased risk of esophageal cancer, and therefore Barrett's, are essentially people with chronic reflux. We are working with, a group in Cambridge who've developed this non-endoscopic screening test that can be actually used in general practice, which is a small sponge that you swallow. And that then takes like a smear of your esophagus. So you get a cytological sample of your esophagus. And we're looking to... I know, it does sound a bit yucky. I always wait until people have finished eating.
Who's collecting it?
So it's our research nurse who's collecting it at the moment. So essentially what we are asking of practices, if they're interested, is to run an audit of all of your records to identify people who are long-term PPIs over 55, and then sending a letter to them inviting them into the study, essentially. If they're interested, then they are then offered the sponge screening test and an endoscopy as well. and it's really to see if this is a test that is as potentially as accurate as an endoscopy. That could be, it's obviously much simpler and could be done in general practice. So if you might be interested in that study, as I say, there's further information on the sheets I've given you and an expression of interest.
What colour's the sponge?
Pardon?
What colour's the sponge?
It's a little, it's like it's the size of a Panadol capsule. And it's a black sponge that's all squished into this little plastic wrapper, essentially. So and it's on a very fine string.
Oh, it's on a string.
So
It
they
comes out which one?
It comes out. So basically, what you do is you swallow it, and then you have a local anaesthetic spray, and then you just pull it out again after 5 minutes. And so it sits in the stomach for 5 minutes. That dissolves the capsule. The sponge expands a bit, and then as you pull it back up, the sponge takes a scraping of your esophagus.
Have you done it?
Yeah, it's a bit. Well, look, it sounds worse than it is actually.
It's a
And
bit like an nasogastric tube.
yeah, it's probably not, and it's actually not as bad as that because it's much smaller. The thing that most people find slightly irritating is just while they're sitting there with the string at the back of their throat. And we've published one big study of it in the UK, and that was on over 500 people. And that was, most people found it actually much more exceptional, obviously, than an endoscopy.
And so you don't get much relief from vomiting?
No. So you get a tiny bit of a gag as it comes out, but the nurses get trained to pull it out very quickly. It's not like one of these reactions. Anyway, if anyone's interested, either contact me or the rest of the team who's based at Royal Melbourne.
The 1st of April, which is Easter Monday. Yes. So what? Sorry. No, you go first.
I was going to say, so are you going to update the forms, or
Yes.
we just?
Yeah, I think we need a bit of update on this.
I will amend and send you electronically. I apologise for the emails with the different forms, so I'll put on the email to say that this is the final version. That I'll email those through tomorrow. John, I'm actually flying out of the country Thursday nights.
Okay.
So, just in terms of the letter.
Yeah, sure. I can sort that out.
Else, if that could be forwarded through before
Thursday.
Thursday, that'd be great.
Is timing, is that essential? Because most of all the buses are going on holidays too.
Yeah.
It's school holidays. So does it matter when it starts?
It does in terms of, I guess, we're looking at a 4-month project, and I guess if it's a staggered start, it's a bit hard to track. When we're looking at wanting to start,
Well, after the school holidays, because half of our doctors
The
are away
15th.
first week and the second half are away second week.
the 15th of April will be the start date.
Couldn't you just move it 2 weeks?
I possibly could, I'm just trying to think.
If you're going to give these out and then collate them, can't you collect a certain amount of these for them to be collated or dealt with after the 15th? You can be collecting 2 weeks worth of these.
And collate them when you get back from holiday.
Yeah, but our patients won't be there. Oh, because they wait for us to.
Yes. But the others will have their patients still.
Yeah, they'll have their.
And then when you get back yours,
So you can still, I'm saying, you can still do
this.
this.
Yeah. And if the skill set level and up, all the ones with a number,
Correct.
all that can all go.
Yeah.
So then you've just got your
Yeah.
level and just deal with. It'll probably take 2 weeks to get them to come back anyway. Because they'll be on holidays themselves.
There's no reason why we can't do that immediately.
Yeah.
In terms of timelines, I don't think if we
I think that'll be okay.
push it back
But
to
to
the
be honest,
15th.
it's going to take a little while for you to get everything set up.
Yeah.
So when is it supposed to finish?
Training and stuff.
It was the 31st of July, but if we push it back, so it's a 4-month project.
And you haven't cut off of how many patients you want in it?
There's no target, if you like, of how many patients are taken, given that it's a long process. But the idea would be that, you know, we're aiming towards as many as possible being offered in the screen.
Yeah, the issue, though, I guess some of the issues is a technical issue against, again, you know, if I've got, I don't know, if I see 20 patients in a day and 10 of them fit into that age group and they all fill in a form and say 4 of them are positive, you're talking about a half-hour consultation, aren't you, as a review? That's every day. It's going to take an enormous amount of time to get through all those people and have them. I think, it's not quite as simple as it sounds.
How many patients are
Depends if
expecting
the
positive? There
doctor-
won't be that many
You
positive.
don't think so?
I wouldn't think so. I think they're pretty.
Well, if everyone feels it's in now, is there any positives? Or just
Yeah, well, I'm positive.
Yeah.
Positive.
So there's just sitting in this table.
Yeah.
Now mine would probably come and go, I might only be in there for 5 minutes, but
So-
Still to make us.
Now, admittedly,
Yeah.
there's probably a response bias in these numbers.
Yeah.
So, in the study, there were probably people who were more interested in their family history that completed this. So, these would be the very upper limit, I would have thought, in terms of the numbers or the percentage.
Yes.
Yeah.
And I hate to be negative. I'm not trying to be negative, but I'm just thinking of all the other thing is the government offers the 45 to 49 health check.
Mm.
And so in a large percentage of our patients, we've actually gone through the relevant Red Book
Right.
information
Yep.
with regard to those patients because we set aside a consultation for
Yeah.
preventative
Yep.
medicine.
So there'll be
Some
some who've
patients-
had this dealt with already.
Yeah, it's going to be sort of,
Yeah.
oh, I'm coming back, but do I really need to come back because I already know all that sort of thing. But I guess if they've got a high risk, they'll probably want to reiterate it anyway. So.
But that's only a small, it's only
Yeah, it's only a
5
small
years.
proportion,
so,
yeah.
Alright, so we're going to start 15th of April. Okay? And that will then push back.
Does that mean it'll finish middle of August?
Yeah. With the participation agreements, I think they won't change, but the dates of the data when they're due will change slightly. But rather than sending out another checklist with the dates, I'll just send a reminder a couple of weeks before the data's due, just as to flag that what date it will be due by, and that will cover that off. Is there anything else?
Well, thank you very much for your interest in this.